So sepsis comes from starting off with a normal infection, and we'll talk about that in a minute. But what sepsis ultimately is a really strong, extreme immune response reaction to an infection. So basically, the immune system within the body over responds to whatever infection it's trying to fight, and the result of that, in a very small cases, a very small number of cases, is that with sepsis, what happens is the body then, in trying to fight the infection, starts to have a negative effect. So the result is that actually it starts to fight what we're doing positively and how our own body responds and our tissues and organs respond. So we start to damage ourselves. So the immune system, in fighting the bacteria, over responds and starts to attack the person itself. So again, what do we know? And one of the things you'll see in a couple of the things that we're going to talk about is that I do know that some of the things are quite vague, or how does that really help me? Because if I can't tell who's going to get it, or if the symptoms are very similar to other things. And so one of the things for us really to go back to at the end, again, is that thought of actually, how do I tell when someone's unwell? So what do we know though? We know that sadly sepsis can affect absolutely anyone, but there is vulnerable groups. Usually with most of the things we think about, there are people that are more vulnerable than others. So particularly relevant to this webinar and why we're chatting to you guys as a group is the very young. So the young are more susceptible, and by the very young we really do generally mean under one, but even toddlers as well. So small children under fives are more vulnerable and more susceptible to infection and to having this negative response, as are the very old. And then, as which is not that uncommon, anyone whose immune system is already weakened or threatened. So anyone who's also got a significant chronic health condition. So those three groups are the most vulnerable. To get sepsis, you need to start with an infection somewhere in your body. That could be quite a simple infection, a common infection, such as a basic chest infection, something like a urine infection. Could be start with a much smaller skin infection, so a small cellulitis that then spreads and develops. The bit that's difficult, and the bit that we don't have an answer to, is we just don't know why some people, so lots and lots and lots of people get basic infections. Why it is that some people develop sepsis from what is ultimately a common infection and others don't, is the bit that people don't really know or really understand. But that does make it quite difficult for us to see it and perceive it and predict it, really, for want of the right word. So we're going to look at both of these two illnesses separately. We're then going to look at the comparisons. And then, as I said, we'll just go back to assessing unwell children. So meningitis is the other term, or the other illness that we often hear about that generally generates anxiety and stress. So when we're talking about meningitis, what do we mean? So meningitis ultimately is an inflammation or an infection causing inflammation of the meninges, and the meninges are a membrane that covers surrounds the brain and then follows down to the spinal cord. Meningitis isn't sepsis, however, the symptoms often overlap, and bacterial meningitis, which is the more significant form of meningitis, can lead to sepsis, and that's when you may well have heard of the term meningococcal septicemia. So meningitis is an infection. If you remember from the slide before, I've just said that sepsis comes originally from an infection. So this meningitis is an infection that, if it's bacterial, is quite likely to lead to sepsis because it is generally a serious bacterial infection. So meningitis can have bacterial origin or it can have a viral origin. Viral is actually the much more common form. And can have life-altering effects, but for the majority of people, it's a relatively minor illness. So viral meningitis, although it's unpleasant, for most people, doesn't have a significant effect. The one that we're worried about is bacterial meningitis, and bacterial meningitis does continue to be life-threatening and need an immediate action. Okay. So Why is it that we're hearing so much more about sepsis nowadays and actually less about meningitis? Well, one of them has a positive answer, and one of them we still don't really have a great answer. So, the main reason we hear so much more about sepsis is actually that there has been a fantastic sepsis awareness campaign, and the Sepsis UK charity have done some amazing work to raise the awareness of sepsis. So, the reason you are hearing so much more about it isn't necessarily that there is a lot more cases. It's actually just that awareness is being raised and people are talking about it much more. Whenever we stop doing that, then actually we hear about it much more. People get a little bit more frightened by it, but doesn't necessarily mean it's become more of an issue. However, we are seeing more cases of sepsis. Now, again, when you unpick that a little bit, why is that caused? Well, one of the things that's really changed is how we record the data. So the data recording process has changed and how we recognise and report sepsis has changed. So if we change the way we record the data, then sometimes that can look as if the cases have increased significantly when actually they may not have increased as significantly. It's just that we're reporting them in a different way. Um, the other thing, though, that we do know, and this will continue to increase for lots of things, is whenever we, or with every year that passes, we have developments within medicine. With every year that passes, our population increases in average life expectancy age. So the more we have an older population, and the more that we can do to help people when they're unwell. And so that's that comment there about that increased use of invasive medical devices. Invasive medical devices can be something as simple, like probably one of the most original ones that we'll all be aware of would be something like an IV cannula. So an intravenous cannula, that's how we give intravenous medicines or how we give intravenous fluids. So when you've seen people with a drip line in their hand, as soon as we introduce an invasive device, we're breaking the best barrier against infection, which is the skin. So as soon as there's anything that goes into the body in order to help someone, then we do increase their risk of getting infection through that route. And so as we can do more for people, we'll see more of a secondary cause of illness. So just, I'm not sure how well I'm explaining that, but someone who maybe has liver disease, for example, previously, if we couldn't do as many interventions to help them, then they may not have got better and the cause would have been recorded as liver failure. Whereas now we're doing more things for those people. They may well be having more invasive interventions, which then for a small minority will lead to an infection. And that person then becomes unwell because of the infection. But actually, if we were able to backtrack them in previous years, they may well not have got even to that point. They may not have survived to that length of time. So we just have to recognise that actually sepsis has increased, but the percentage in which we're seeing more sepsis is really not that clear. And it's not definitely that there's loads more cases of sepsis happening in the country. It's just we're talking about them more, we're recording them in a different way. To flip it onto something that's much more positive, there is a very clear reason why you are not hearing about meningitis as much. And the reason we're not hearing about meningitis as much is that we have had an incredibly successful national immunisation programme that has enabled us to vaccinate against two of the forms of bacterial meningitis, which has significantly dropped the number of cases that we're seeing. So actually, we don't hear about meningitis as much because genuinely there are not as many cases of meningitis. We hear more about sepsis, partly because there are more cases, but how much that is to do with the interventions that we can make going up and how much that is to do with recording data in a different way and recognizing sepsis, that's where no one's really quite sure of that percentage and that jump. So we're going to have a little think about some of those red flags. And one of the things that I'm imagining some of you will be looking at this and thinking is, well, that sounds like a lot of other things. The purpose of telling you the red flags is really to help you think, one, I'm really going to push this because I've seen something here that we've talked about, and I know that this could be a risk of sepsis. And until someone tells me it's not, I'm going to ask to be seen again, or, and we'll talk about this again at the end, until someone can give me a rationale to why they believe that what I'm seeing isn't that sign of sepsis, then actually it's just a little trigger for you. The other thing that this might help with, I think, is one of the discussions, and I realise we'll have a mix of an audience. I know I've got some of my first aid colleagues on the call. We'll have a lot of those of you who work in a child care background, looking after children and responsible for other people's children. And then I know I've got some parents, particularly for those of you that work in a childcare setting. Some of the things, if we think about some of these red flags, they might be the thing that says to you, actually, we've contacted this child's parent, but this is the thing that's going to make me say, I'm not waiting for that parent to come. I think we need to call an ambulance and the parent can meet us at the hospital. Actually, we need to get this child seen more quickly. So, some of the signs of sepsis in older children. So, breathing fast, and by breathing fast, I don't necessarily mean panting particularly or hyperventilating or panicking. What you're really looking at is a child who is working harder to breathe. And again, we will come back to this at the end, but whose respiratory rate has increased. They're breathing more than normal. Might well be something that's a red flag to you. And breathing is a really useful indicator in children. Those of you that joined me before, I will have said this before. How a child breathes, the amount of effort and the amount of energy they're expelling in their breathing is a really, really useful way for you to quickly see, actually, maybe this child isn't very well, and maybe I want someone to look at them. A fit or a convulsion, and this is one I'm afraid that's going to come up with sepsis and meningitis. However, for me, it's not necessarily the most helpful one here today, because I think probably most of you would respond to a child who's having a fit or a convulsion that doesn't have an explanation, you weren't expecting it, and who doesn't seem very well after the fit or the convulsion. So that one, yes, really good indicator that you need some help, really good indicator that you probably need to respond to this unwell child. In these two scenarios, a really good indicator that this is really quite an unwell child, but I think it's probably not the one that you're going to necessarily ignore, whereas some of the others might just help you at an earlier stage. The next one is that they look mottled or blue or pale. Um, Again, apologies if the analogies are the same, but we used to really refer to this mottling, and we talk about mottling quite a lot. I put some pictures up last time, but we talk about mottling, and it's quite hard. If you don't know, if you've not seen it, it's quite hard to understand. And we used to always refer to it looking like corned beef, which I think is an outdated, useful analogy now, because not many people know what corned beef looks like. But it's really that marbly look. So it's skin that's pale, blotchy, and you can often see the veins, so the little capillary veins standing out quite clearly. So the capillary vessels rather standing out quite clearly, but the rest of the skin is very, very pale. And there may well be a bluer tinge. I'm not talking about blueness around the lips. This is more of just to the skin colour generally. It's a pale, it's a grey colour. It's not, just doesn't look right. For children with darker pigment skin, actually that's harder to see. It is much harder to see on whiter skin, but where you can look is in the areas that are paler. So often the inside of the forearm is a good area to have a look on darker skin. Inside of the mouth, I think that's quite a tricky one. The data will tell you to look inside of the mouth. Personally, I've never found that particularly easy. The palms of the hands or the forearms are often helpful. We've got this rash that doesn't fade with pressure. I'm going to come back to that one at the very end and go through that one again. They're sleepy. They're hard to wake. This is one that I will want you to just take on board for any child. Behavior is my thing. Behavior, behavior, behavior. Take that away as your message. If a child is not behaving in their normal way, so this is a child who is really sleepy and floppy, not just had a longer nap, but now bright and alert again afterwards, actually needed a nap in the morning, needed a nap in the afternoon. They're not 100%, they're a bit grizzly, but in between they're great. And again, we talked last time about that roller coaster effect. What I mean by that is children, when they're unwell, have peaks and troughs. The children we're talking, and that's normal pattern. Generally, they perk up, they feel a lot better. It's usually once they've had an antipyretic or pain relief in some way, so they feeling a little bit better, and then they dip back down, and then they come back up and they dip back down. Um, Now, the one that is useful to hang on to and to sort of think about um, is that a child who is recording, so again, nurseries, I know you're quite obsessed with taking children's temperatures, um, and sometimes that's helpful, sometimes that's not. If you came to my febrile convulsion session, we'd have talked about how it's not actually the number on the scale, it's how it jumps. But what is really helpful and unusual in sepsis is once a child is becoming really quite unwell with sepsis, they no longer record a high temperature. They're actually likely to record an abnormally low temperature, so cold. So on your thermometer, they'll be recording as hypothermic, so something around the 35 region, also, the 35 point mark. So well under 36 degrees. And that's unusual for a child. Probably most of you haven't seen that on a thermometer. You've seen 36s, 37s, 38s, 39s probably, because children get high temperatures. They may well have started initially with a temperature, but now they're recording a low temperature. And a low temperature should be a real red flag for you with an unwell child. Not with a child who's running around and cartwheeling around the place. That's probably your thermometer failing you. But a child who's unwell and is now recording a low temperature. And there's a few reasons why this happens. So I said to you before that the body is fighting itself. So the immune reaction to the infection is now starting to have a negative effect on the body. So we have vascular dysfunction, so failing of the vessels. And at this point, they dilate quite dramatically, and that's a lot easier for us to lose temperature through dilated vessels. Our brain is not working efficiently. So I've said we're attacking those organs. Our thermostat, our body thermostat lives within our hypothalamus in the brain, and that starts to fail. Or just particularly because the immune system is overreacting and it's having this extreme response, what it can do is then suppress the mechanisms that normally help us to control temperature. So sepsis is a really unusual one where we see very low recorded temperatures as a quite significant sign of a very unwell child. So you recognise someone was ill, maybe they came in already, you thought this morning, this child shouldn't be here, they've clearly not very well, and you're trying to get hold of someone, you're waiting for them, but actually they're breathing more quickly, they're not really as alert as normal, and you now have taken their temperature, and their temperature is 35.2, and you've gone and got every thermometer you have in the place, because most of you have more than one in each children's room, so you have a couple around, you've checked it 2 or 3 times, and you think, no, this child's actually cold, they're not hot. That might be one of those indicators to say, you know what, we're not going to wait for the parent to come, we're going to call an ambulance, or we're going to get paramedics to come and review this child. The red flags in the under 5s are those that we've included before, but then we generally really focus here on fluid input and fluid output. Feeding, not so much as in food. By they are not feeding, we mean infants who are still bottle fed or breastfed. But in your scenario, they're going to be, I'm going to guess, either express bottle fed or bottle fed. So are they not taking fluids in? Are they repeatedly vomiting? Or particularly, are they no longer producing very much urine? And that's, again, back down to our organs are not working effectively, so therefore our kidneys don't work as well. I'll come on to irritable in a second, but irritable is just that unable to pacify. It's very different, and you guys will be brilliant judges of this. Children, as you know, are grumpy but often easily distracted. So whatever you're doing, this is very out of character for them. It's back to behavior again. It's really hard in a child who's quite easily irritable anyway. That then doesn't necessarily stand out as well. But your child who's normally really, really quite chilled, very easy to distract, might get upset about things, but can usually move on, who's behaving just differently to their normal. Okay, so what you will notice is meningitis, some of those things have an overlap. And I sort of, as I said before, it doesn't really matter. Um, but we're looking at both of those two. It may well be that you recognize just an unwell child and you're going to get help. Or it may be that there's a couple of these signs that resonate with you and you're in a situation where you think, actually, for either of these two illnesses, oh, okay, I've got a red flag here. So meningitis, far more likely that the child is still going to be hot. Obviously, if it's meningitis septicemia and we're very sick, but I would hope by that point you have already recognised. One of the big differences with meningitis is obviously a child's going to complain of a headache. That's because I've said that this membrane is inflamed and angry. Um, what it does tend to be, frontal headaches are common, especially with the temperature with children, but it's just quite an intense headache that's very different to normal. Vomiting and diarrhea, I think, are the most unhelpful to signs and symptoms for anything because they come with absolutely everything from illness that you're not going to respond to illness that you are, but may well see vomiting and diarrhea. Muscle pain, again, is quite difficult because lots of things cause us to have aches and pains, as with stomach aches. So some of those last four are not particularly helpful, but some of the others will be a little bit more. With meningitis, we're more likely to, as I said, be hot. And when children are hot, they tend to preserve their blood supply within the center of their body and their brain and their peripheries, their hands and their feet. The body will naturally constrict those vessels, so shut those down in order to preserve their blood supply in the important essential places. So you'll often notice cold and quite significantly different cold hands and feet. So a burning hot body, but cold hands and feet. The confusion and irritability is quite helpful because this is slightly different. So we're thinking about this child who's got an inflamed membrane around their brain. So they're usually in quite a lot of pain. Confusion for any child should be something that makes you have a red flag. And we'll think about the irritability in a second when we come on to the babies. Dislike of bright lights, again, quite helpful. Doesn't happen to very many other things. So that's when we refer to photophobia. Any of you that have migraine will probably have experienced this. Under fives don't tend to present with migraine. It does come in childhood, tends to come in older childhood. So there's not many things that cause that photophobia sensation in children. It's definitely worth, if your child's also unwell, definitely worth getting them seen and checked. My little trick for that probably doesn't help so much in a child care setting, but for a parent it does, is that this is about the response of the optic nerve that's touching along the spinal column and around the brain, and the response of the optic nerve when it dilates to close when we're in bright environments. The same thing will happen if a child looks at a computer screen, a TV, or a phone, or an iPad. So if you think that your child is not liking bright lights because you've walked into a room where they were sleeping and switched all the lights on, turn them back off, gently take them somewhere calm and quiet and sit, put a telly on, let them look at an iPad or a phone, all the things that we generally don't want them to be doing very much, but they do a lot of. If a child can look at the bright lights that are coming from that, they haven't got photophobia. So think about those environments where can I stimulate the same response and see if they are also, probably for most of us, a child who doesn't want to look at a television, a phone or an iPad would be a red flag. Neck stiffness is really a helpful one, but it's good to clarify it. So by neck stiffness, we mean literally the stiffness of the neck. So again, I want you to visualize this inflamed membrane around the brain and traveling down the spinal column. The reason the child is stiff is that if I move my head forward, then I'm pulling on this already inflamed and angry membrane and moving it around. I don't want to do that. So we are talking about a child who literally looks like you will have done if you've been involved in a car accident where your head, your shoulders and your neck are all running in one line. So again, actually just ask the child to move their head around. They might not understand that term or they might be too young. My general trick with that is just a torch. I mean, you can use the one on your phone. You've probably got one. Shine a torch around, move the spot around a room. Most children will, even feeling rotten, even little babies will look and follow that with their eyes and have a look around. They're moving their head, That's not the same. Toddlers will often refer to a sore throat as a painful neck. So it's not so much a painful, it's that stiffness. Convulsions we mentioned before, and I'm aware of time, so I'll speed up a tiny bit. Convulsions we mentioned before, yes, definitely respond to a convulsion in someone who you do not know has convulsions, and definitely in a convulsion that isn't bright and alert and responsive afterwards. And that drowsy and hard to wake we've already mentioned. So babies and toddlers, very similar. Lots of them that are exactly the same. So we've already talked about the cold hands and feet, the drowsy, floppy, that I'm coming back to the cry, refusing feeds and not having a good oral intake, and that increased respiratory rate. The two that I really want to stand, and the neck stiffness is very similar to younger. The two that I really want to get you to notice here, because I think they're really unusual than many other illnesses. So there is something about an unusual cry or excessively irritable, moaning baby that should stand out. I may have said this last time too, but um, when I was a mum, I definitely, or a new mum, still a mum, I definitely wasn't that person who could say, oh, that is the cry of a hungry baby, or that is the cry of a baby who needs to be changed. I knew that he needed to be fed because I hadn't fed him for a while, or he needed to be changed because, again, I hadn't changed him for a while. But the cry of pain, as a general rule, I can often walk through children's A&E with babies in different areas, not necessarily be knowing about them. And I'm sure many of you will have experienced the same at your work environment, where I suddenly hear a cry that's a really different, it's usually quite high pitched. And it's a cry that says, that is a very unhappy baby. That's a cry of pain. And it is quite different than most other childhood cries. So a toddler that you're used to, a baby that you're used to, who's crying in a different way is often a cry that says, I'm in pain. Now, the one that I think is really helpful is this not wanting to be handled. Most parents, when they bring their child to me to be assessed, will say to me, oh, they're not right. I can't put them down. They just want to be on me. They want to be on me all the time. They're fine. I can settle them down. But the second I put them down, they cry. Unwell babies want to be loved, cuddled, fussed over. But let's think about again what's happening with meningitis, and I talked about that inflammation around the brain and back down the spinal column. What we tend to do with little children when we cuddle them is we curl them up. We tuck their heads in, we tuck them into us, and we often curl their back in cuddling them. So when we have meningitis and we do that, we're stretching on that bit that's hot and angry, and that baby won't want to do it. They will push away from you and they will arch their back. So a baby who doesn't want to be settled by being picked up, there might be other reasons. Reflux quite often does the same thing. So if you've got a reason for it, that's absolutely fine. But something that's together saying this child is not right and I can't settle them by handling them might just be one of those things that flags to you as this is not quite right or different. Okay. So we will have opportunity for some questions and ask those things at the end. But I just wanted to come. So they are the what we've just run through are some of those just helpful red flags to just try and explain sepsis and to try and explain meningitis. So you've got a couple of the things that might say, okay, this is different. And actually, if you're suspecting sepsis or you're suspecting meningitis, then you want to get that person to be assessed by someone with clinical experience as soon as possible. And it may well be that they assess them and they tell you that actually on this occasion, for whatever various reasons, you don't need to be worried, but you need them to be reassessed. But what I wanted to just try and come back to is just a quick recap, and this one will only be quick, about some of those things that we want to look for normally to just understand normal childhood illness, because otherwise you'll leave this webinar totally terrified, and that's not really the idea. This is about, again, gaining your confidence in how do I know when something is more serious, because children do get unwell. Children get unwell all the time. And as a general rule, they get unwell and then they get better again. But we are all naturally fearful, and it really doesn't help anyone who's working with children, but also any parent, because we only ever hear the horror stories. And then we have too much access to information nowadays. Not so much, I think the internet is good, it's useful, and it's helpful. There's lots of good information out there and good guidance. Social media, I don't necessarily feel the same about. So you can often get just totally confused and bombarded with information and thinking, I don't know if I should be worried. The things that I really, really want you to think about and focus on is, what am I looking at? How do they look? What is their appearance like? Am I looking at this person and do they look unwell? So are they lethargic? Are they floppy? Are they pale? Are they just looking unwell? Are they disinterested? Behavior. So I will come back to some of these things in more specific detail. Behavior. What are they doing? And then particularly is there anything we can measure? So again, we did talk about these before. We're just looking at them in a slightly different way. So let's break them down just quickly. So appearance, how alert are they? How responsive are they? How interested in you are they? Are their eyes bright? Are they looking around? Or actually, do they look quite drawn, dark shadows under their eyes? What's the colour of their face? Flushed isn't usually such a problem. So when we get hot, we get flushed. What's their usual colour? Do they look much paler than normal? Or are we seeing that mottling? And then posture is a really, really helpful one. Tired, especially smaller, younger children, will become floppier and unable to look after and maintain. Heads are incredibly heavy in small children. They are proportionately so much bigger on the rest of the body. So are they upright? Are they sitting comfortably? Are they looking strong? Or actually, are they slumped? Are they floppy? Are they more, is their posture more lax than it normally would be? Are they only wanting to lie down? Do they not want to be held and cuddled? What are they doing? It's my favourite of all. So behaviour absolutely tells you so much. What is that child doing and what are you worried about? Because you're probably picking up on something. So actually, is there a reason for it? Or do you need to find a reason? Do you need someone to review it? So irritability, children that are just, and especially in the under ones, an under one who you cannot console should be reviewed. So are they crying? Are they fussy? Do you have a reason for it? So under one, you've been looked at. We can see that they've got a really nasty ear and throat infection. Actually, they're doing that roller coaster. May not worry me so much if they've been seen, they've been treated, you're on some antibiotics and they pick up. But you're under one who will not settle, then you really want to do something about it. Pain that doesn't go away with pain relief on the whole, and this is quite a big generalization, but life is too exciting when you're young. They don't have the world's problems on their shoulders, so gentle pain relief should relieve most things. If a child is so, if the pain comes back as the pain relief wears off, that might make sense, and you need to work out: do I know why they're in pain? Have they fallen, bumped their head, and they're going to have a bit of a headache for the rest of the day? But actually, pain that doesn't settle with gentle analgesia, you want to question. Activity and interest is great. One of the things that really resonates always with me is small children who were not interested when a parent or a sibling comes home from work, comes home from school when they normally would. So a parent who comes in and says they've been irritable all day, they're very, very unsettled, they're not really paying attention to anything that's around them, they're not really interested in anything, their brother and their parent came home and they weren't interested, would be something that would make me just want to be a little bit more concerned. And then what are they interested in doing? Are they doing their normal daily activities? Are they eating and drinking and playing, or are they doing none of those sort of things? The sort of signs we can check are temperature. So are they hot or cold? Have a look at their breathing. What is their breathing like? There are not many things that affect our breathing that are external. So if a child's working harder to breathe, using more effort, or breathing faster, then that's quite a good indication that they are not well. Fluid in and fluid out. So are they drinking their normal sort of amounts, and are they passing their normal sort of amount? So wet nappies, be fairly relieved and relaxed. dry nappies, be concerned about it. Haven't been to the toilet. And then the last one, just for us to quickly think about, is the glass test. Now, we talked about that before. The bit that I actually want you to look at is the orange bit first. Do not wait for a rash if you are worried about all of the things before. So we may well see a non-blanching rash in both sepsis and meningitis. And what's happening in a non-blanching rash is the small capillary vessels are dilating and bursting, and you're having tiny little bleeds under the skin. Now, that doesn't happen for everybody, or if it does happen, it's a very late stage. So if you've already seen enough things that are bothering you, then go and seek help. But if you do see a rash, so we talk about the glass test, but really what we're doing, and I know it's hard for me to show on this, but you're putting pressure against the skin that removes the blood from those tiny little capillaries, so it will turn the skin white momentarily. Then you release that, so you push the glass against, it will go white underneath, and you release it, and you're looking at how quickly that blood returns to those capillaries. There are other things, and I do want to just add that in here. There are other things that can cause this tiny little bleeding of the capillaries. So actually repeated vomiting, a lot of coughing can cause a small non-blanching rash on the chest, across the face. It's not for you to need to worry about whether that's right or not. You want to, any child with a non-blanching rash needs to be seen. It may well be that you're seen and someone can reassure you that actually they vomited a lot. The effort of vomiting has also caused those tiny, small little petechial spots. So yes, you were right. Yes, they are tiny little bleeds, but actually in this instance, we don't need to worry about it. So the last one, just to think about, and we did talk about this before, I really think that it is important that everybody, on a daily basis, I would hope that this is what I'm doing, is reassured that if I go to see someone, now, hopefully, if you go to see someone and they're looking at in the instance, then what they're saying might be something that you need to listen to. But actually, if anyone has only ever seen your child or the child you're presenting with in a snapshot moment, children do change, situations change, children deteriorate. If your gut instinct is telling you, no, they're still not quite right, I am still worried, or more importantly, something's changed, never, ever, ever feel bad about representing, never, ever feel bad about going to see someone again. But also, my biggest tip, and this is probably more for parents than it is for carers, is that when you go to see someone with your unwell child and they say, actually, this is a viral illness, they're going to be unwell for a little while, but I'm not worried that we need to do any intervention now, and you're hopefully happy with that as well, it's really, really good to say, great, but if it's not obvious to you, so what should I be looking for and what would you want me to come back with? So that's called safety netting. Everyone should do it in their clinical practice. Obviously, people do it better than others. So make sure that you are comfortable with, well, what would those safety nets be?